So this study has to do with patients that have rheumatoid arthritis, and specifically about an infection that they are more prone to get, which is influenza. It is really important that the concept is that people that have rheumatoid arthritis have an increased risk of having influenza, but also an increased risk of having more severe complications, which is called influenza-related illness. And because of this, they are a vulnerable population. But there's another aspect of this, which is the fact that the medications that they receive and the disease itself, the age of our patients, and also the fact that many of them do have comorbidities makes them more less susceptible to develop protective antibodies when they receive vaccines. So there's a two aspect of this. On one hand, the increased risk, and on the other hand, the increased response to the most effective way to prevent this infection, which is vaccination. So the reason why we developed this study is because in a different population, which are people are above age 65, the elderly, which is also vulnerable to have more severe complications of influenza, using a high-dose influenza vaccine is associated with a 25% decrease in the risk of influenza and influenza-related illness. So since people that have rheumatoid arthritis and the elderly share similar mechanisms that make them more prone to this infection, we thought that maybe, similarly to what happens in the elderly, people with rheumatoid arthritis would benefit from getting this vaccine. So this is essentially the rationale for this study. The way we tried to test whether, in fact, the high-dose vaccine was beneficial for people with rheumatoid arthritis was by conducting a randomized controlled trial. So this was a single-center study. It was done at McGill. It was stratified according to the background treatment that patients with rheumatoid arthritis were receiving for the last 3 months prior to enrolling into the study. It was double-blind, and it was active control. So every patient that participated in the study received either a standard dose or a high-dose vaccine. The two vaccines that were compared were both inactivated formulations, which are the ones that need to be given to people with rheumatoid arthritis. And it was a high-dose trivalent vaccine versus a standard dose quadrivalent vaccine. And this study was done, as I said, during 2 consecutive years, 2016-17 and 17-18. The readouts of this study were the development of antibodies protective against each of the strains contained in the vaccines, which essentially in the trivalent vaccine are 3 strains and the quadrivalent vaccine are 4 strains. And we did this by a standard method, which is called hemagglutinin inhibition assay. Now, the factors that we looked to say whether the study was effective or not was to look at seroconversion rates and seroprotection rates. These, again, are 2 measures that are used for vaccine studies that, in the case of influenza, is looking at, in seroconversion rate, what is the percentage of people that had baseline antibodies undetectable, and at day 28 they had antibodies at titers 1 in 40 or higher, or people that baseline, between baseline and day 28, they increase 4-fold the titers of their antibodies. That's seroconversion rate. Seroprotection rate is at day 28 the number of patients that have titers of HI antibodies equal or higher to 1 in 40. Now the question is, okay, why are we looking at these particular titers? And the important concept here is that titers of HI equal or higher than 1 in 40 are associated with a 50% reduction of infection at the population level. So there were 280 patients that were vaccinated. 139 were in fact received the high-dose vaccine, and 140 received the standard dose vaccine. And the outcomes, the primary outcome, which was immunogenicity, was evaluated at day 28, whereas the secondary outcomes, which were among them, the one that we presented here, was adverse effects, so safety, was evaluated at day 186. So what this study showed was that the percentage of patients that achieved titers that are protective was higher for all the strains in those that received the high-dose vaccine compared to the standard dose vaccine. And in fact, that people that received the high-dose vaccine were 2 to 3 times more likely, after adjusting to other confounders, to be seroprotected than those that received the standard dose vaccine. In terms of safety, what we saw is that the rate of side effects that were reported were about 30% in both groups. The specific adverse events related to reactivation of rheumatoid arthritis, which was one of the concerns. If we are giving a higher dose of an antigen, maybe that could trigger a flare of rheumatoid arthritis, was absolutely not different between both groups. And in fact, there was no evidence with the ways in which we assessed this, that neither at day 28 nor at day 186 there was an increase in the disease activity compared to the day 0. And in terms of severe adverse events, overall there were 3 patients that had severe adverse events, but 2 in the high dose and 1 in the standard dose group. But none of those 3 adverse events were considered to be related to the intervention. There was 1 patient that died, unfortunately, who was in the high-dose vaccine. That happened very close to the end of the study, so very close to day 186. And that patient that I know very well died, and we have the confirmation that the reason why she was admitted was because of influenza, and the reason why she died was because of an influenza-related illness. So personally, what I think about this is that even if that patient was in the high-dose vaccine, there is a large need still to make sure that our patients do have interventions that can protect them against this. So this is a step forward in terms of improving what we have, but in no means is the definite answer to our patients. I see that there are 2 things that are very important. The first one is that this is the first randomized controlled trial that has ever been conducted in people that have rheumatoid arthritis, comparing 2 different vaccine doses. And due to the design of the study and the relevance of conducting these type of randomized controlled trials, the findings that they show are extremely important to then move forward to the next step, which is to see, okay, is this if there is a decision to start using the high-dose vaccine among patients with rheumatoid arthritis, is this intervention effective? So what we have done is an immunogenicity study. It's not an effectiveness study. Effectiveness can be evaluated once the vaccine is used, and once we are able to see to what extent that intervention decreases the number of clinical events with among these patients. So I think that is one of the strengths of the study. The second thing that I think is important is that, in a way, having these results stimulates other researchers also to think, to develop new and better studies in this area. And by doing that, I think that also is going to, in the long term, be able to reduce a comorbidity that can be preventable. And the last thing that I would say in this regard is that this study is a proof of concept of the fact that high-dose vaccine is not associated with increasing disease flares, and that, of course, the question is, okay, that titer of 1 in 40 is really protective in people that have rheumatoid arthritis. I said that that is protective in the general population, the healthy individuals. So there are lots of mechanistic studies that can derive and will derive from this study. We have obtained samples to do those mechanistic studies to try to understand better why certain patients responded, why other patients did not respond. And I think that that also will contribute to think about better strategies to optimize immune responses in this population. There are many things that need to be done and can be done. On one hand, a high-dose vaccine is not the only strategy that is possible to use in order to enhance immunogenicity. There are other types of vaccines which are called adjuvanted vaccines that can also be used for this purpose, and there's no study that has used those vaccines. There are also newer vaccines that have different ways to activate and contain different antigens in the vaccine that can also be interesting ways to see whether we can enhance immune responses against influenza in these patients. And then the other thing that I think needs to be done is we need to understand exactly why there are certain patients that are on certain medications that do respond, and there are other patients on the same medication that do not respond. So I really think that there's a lot of, again, mechanistic studies that will help us to learn more about the disease and the way in which, when we use certain treatments, we not only modulate the immune system to prevent disease activity, but also we may affect the likelihood of that patient to have certain other infections.